Good morning. Thank you for giving me this opportunity to share with you how our prospective implementation of multidisciplinary obstetric care reduces maternal mortality in pregnant women with sickle cell disease in Ghana. This is a cartogram showing the burden of sickle cell disease by the year 2050. And as you can see, presently, sickle cell disease accounts for more than 300,000 births annually. More than 79% of these births are in sub-Saharan Africa, of which Ghana, where I come from, is part. Ghana has an estimated population of 27 million people. The prevalence of the beta S gene is found between 15 to 30% of the population. 2%, translating to 15,000 newborns each year, are delivered with sickle cell disease. This is high if you compare it to approximately 2,400 babies in the US and 300 babies in the UK born with sickle cell disease each year. Currently, there's increased survival into adulthood. More patients are getting pregnant. At the Korle Teaching Hospital, where I work, approximately 1,400 women with sickle cell disease of reproductive age, that is ages between 15 and 44 years, are seen each year. At the antenatal clinic, approximately 250 pregnant women with sickle cell disease are seen each year. If you look at this number, this is high. And currently, our antenatal clinic at the Korle Teaching Hospital sees approximately 11,000 women each year. And the 250 pregnant women with sickle cell disease could easily be lost within this crowd. Recognizing this problem, the leader of our team, Dr. Samuel Opon, who is an obstetrician, created a sickle cell antenatal clinic in 2011. In the first 3 years of the clinic, the mortality rate was approximately 12 to 15% each year, and this is high. So, recognizing this problem, he put together a multidisciplinary obstetric team. The multidisciplinary obstetric team included obstetricians, pediatricians, a hematologist, midwives, nurses, and then an anesthesiologist. And we hypothesized that implementing a multidisciplinary team, including a hematologist, for care of pregnant women with sickle cell disease would significantly decrease maternal mortality. For the pre-intervention period, we conducted a 15-month retrospective chart and autopsy review of 158 cases. For the post-intervention period, there was prospective enrollment of all pregnant women with sickle cell disease, followed up till 6 weeks postpartum, of which we had 90 cases at the Korle Teaching Hospital. And then, as I said, we implemented a multidisciplinary team. We achieved an 89.1% relative risk reduction in deaths in pregnant women with sickle cell disease in 13 months. In the pre-intervention period, there were 15 maternal deaths with 139 live births, and this translated to a maternal mortality ratio of 10,791 per 100,000 live births. In the post-intervention period, there was only one maternal death with 85 live births, and this translated to a maternal mortality ratio of 1,176 per 100,000 live births. That rate is still high if you compare it to what is found in the institutional hospital, that's Korle Teaching Hospital, which is 540 per 100,000 live births, and in the US, which is 14 per 100,000 live births. Additionally, we achieved an 18.8% reduction in cesarean deliveries because care was improved and problems were recognized quite early. We also had a 62.2% relative risk reduction in perinatal mortality in 13 months. Our future prospect is to implement a similar program at 3 major health facilities in Accra, Ghana. Collectively, these 3 hospitals cater for approximately 200 pregnant women with sickle cell disease each year, and then would go a step further to identify risk factors for perinatal death, an adverse outcome that occurs regardless of whether they are in high or low income countries. And then we would want to establish a comprehensive sickle cell disease center of excellence in Accra. These are my co-authors and my SCOP team. Thank you.